Essentially, I'm going to be talking about the data that has shown over the past 10 years that people with intellectual disability are like the general population. Obesity is an enormous problem. Physical inactivity is a large problem. And there's endless data sets and observational data sets that show that people with intellectual and developmental disabilities tend to be like the general population, and sometimes even more obese and more sedentary. The milder the intellectual disability, the more likely the person is like the general population. So the people who are functioning at the lower end of the range, they're actually they have lower levels of obesity because someone else is taking responsibility for their diet. But as they move towards the general population, their obesity rates are at very high rates. Hi, I'm Suzanne McDermott, and for one thing that makes me different from many of the others is that I'm an epidemiologist. One of the most important things about epidemiology is asking the question, who's the comparison group? This morning when we listened to the talk from the NCI indicators, they talked about the proportion of the population who has obesity being very similar between people with IDDD and people without. And as an epidemiologist, I always want things to be controlled. If we compare people who are poor, and people with disabilities are primarily poor, the rate of obesity is actually lower amongst people with IDDD. Now, I know most of you in your own personal experience see people with IDDD as overweight, more so than the general population, but that's because you're using the wrong comparison group. You're comparing them to people of all income levels, and we really aren't making fair comparisons. And I have to say this, to get it off my chest, the same thing is true about employment. If we compare the employment of people who are poor to the people with IDDD, it's not going to be this vast difference. And I don't buy into your, it's my hope and dream that 75% or whatever your goal is are employed. But if you compare them to people who are poor and living under the similar income constraints, it isn't as stark as you've led us to believe. So that's where I'm coming from. Today I'm going to talk about the issue of health and wellness. Health and wellness is central. I agree. It is a central concept. When we started doing work in this area a number of years ago, we asked people about obesity, about why did they want to lose weight, people with IDDD. And the answer was always one of two things, pretty much across the board. They wanted a boyfriend or girlfriend, and they thought they could look cuter if they lost a little of this weight, or they wanted a job. And the job, they knew they'd have to stand on their feet longer, they'd have to be healthier. And so the issue of health and wellness is central to many aspects of life. One of the things that, in terms of we all know that being overweight and being physically inactive are risk factors for everyone in terms of cardiovascular disease, early death, premature death, limitations in mobility, and all those things. And there are enormous challenges for people with IDDD because that population lives in a special world where they don't drive cars, so getting to places if you're overweight and physically inactive becomes more of a struggle than it does for the general population. There are many things that set that population apart. And as I believe is the case, the general population in the United States, 30% of the population in our country and in the UK and in many developed countries of the world is approaching 30%. So it's a generic problem. It's an enormous challenge. If you increase the definition and include people who are overweight, we're talking about half the population is struggling with these issues. So it's really important to find approaches. Research has told us, and there's just hundreds of articles. The brochure that was handed out a few minutes ago, the past 5 years, I've been a co-editor of the Disability and Health Journal. We get submissions from around the world. These struggles for overweight and obesity and physical inactivity are worldwide. And there's been enormous efforts to measure how big the problem is, and observational studies and quasi-experimental studies to look at approaches. My feeling was we need randomized intervention trials. Again, that's the gold standard in epidemiology and in many aspects of medicine and social science, and I thought we have to be able to get that kind of work funded. We often talk about there's a dichotomy of opportunities for people with IDDD. One is find evidence-based programs for the general population and plug people in with IDDD and say, okay, now we've solved the problem. We don't have to do our own intervention trials, our own randomized intervention trials, because we know this intervention works over here. Somebody else did a randomized intervention trial. But the question, that isn't the right question. The right question is, will it work for this group, this subpopulation, as well as it works for everybody else? We need funding for that kind of work. But we also need specially designed programs that take into account the concrete thinking, the special learning styles of people with IDDD, and that's what I'm primarily going to talk about this afternoon. Okay, again, one of the things that is discussed this morning is this whole issue of the environment in which we live. We can't just take people in a group home and expect to do something and make it happen. We have to think about the environment, and the world is full of studies that have shown that the physical environment, whether there's sidewalks, whether there's adequate lighting in the evening, whether people feel safe outside, these are enormously important contributing factors about how physically active people become and sustain. And if you go around, I think you all should, to the group homes where people live in your communities and ask them, do they feel safe at night? Is there adequate lighting? Can they cross the street safely? Are there sidewalks? Like many other people in poverty, the answer is going to be no. We don't put our group homes primarily in neighborhoods that have all those attributes. And that's an issue, and that's a struggle, and it goes well beyond the issue of obesity and physical activity. It's kind of a community approach, but a community problem, but it's something we have to take into account. And of course, having the availability increases moderate and vigorous physical activity. That's what MVPA stands for. When you have things around you that cognitively trigger you to do something, you do it more, you're more likely to do it. Of course, you can also lay your clothes on top of your walking machine. So these are all barriers to physical activity. And when people have gone out into the community and studied people with ID in large studies, we found that a small proportion of them actually reach the guidelines that are expected. And that, so the physical activity is a challenge as well as the obesity. Okay, so we did our work in kind of a backwards pattern, speaking in terms of the quality of the research. We started out with a program which was called HELP, Health Education Learning Program, which was designed for the general population. We integrated people with IDDD into that program. So that was that first model that we had. And we said, the goal of this particular program was to lose weight, and everybody who entered the program was either overweight or obese on both sides, the normal learners and the people with IDDD. And we found that although a smaller proportion lost weight, there was 18% of those with IDDD who lost at least 5 pounds. It's given as a percentage of BMI. Your BMI, the number of pounds per BMI depends on where your BMI starts. So we're talking about a 5 to 8 pound reduction. And we got some reduction in the people with IDDD, but not as much as in the general population who chose to enter that class. So that was self-selection and trying the model of using what already works. We found some of the feedback from the participants with ID was that, they didn't understand all the handouts, all the instruction, all the teaching. So we decided to take an offshoot and pilot test a more participatory program that used the same curriculum. And so we went from this HELP program to this Steps to Your Health program, which was very participatory, action-oriented, but again, it was people who wanted to participate, who felt they had a problem either with being too inactive or being overweight. And we found 26% of them lost at least 5 to 8 pounds from what they started over an 8-week period. And then we decided, no, we have to take this to the highest level and do a randomized intervention trial. And so the CDC did fund it. The purpose of the study was to investigate the efficacy, so under the best of circumstances, what led to increased physical activity and reduced weight gain, not even weight loss, but just reduced weight gain, and improve quality of life amongst people with ID living in the community. And the two hypotheses were, one was that they would increase their moderate and vigorous physical activity, and the second was they would not increase their BMI, compared to people who were randomized to the other intervention. We recruited people from a network of community service providers who provided services both in people's homes with their families, these were all adults, or in group home settings. It didn't matter what kind of supervised apartment they lived in. We included people who were 18 to 64 years of age, and they had to be able to learn and get knowledge, be able to take in the information that we were provided. So we used the short portable mental status exam, and they had to get more than 4 things right, like what's your address, what's your phone number, who's the president, who's the last president, that kind of thing. And we excluded people with, we didn't exclude them from the classes. This is, we're nice people, and we included everybody, but we only collected data on the people who didn't have a whole lot of different medical complications that would have made this very difficult to analyze. So we excluded people with complex medical conditions that, we used wheelchairs for mobility, and other people who couldn't get their BMIs measured. And we wanted to use an accelerometer. If you know what that is, it measures, it's much more sophisticated than a pedometer. It measures the intensity of your physical activity and the duration of your physical activity, not just the number of steps that you take. And the conceptual model is that essentially if you attend the classes, it's an 8-week program that includes a lot of participation. Your knowledge will go up. Because your knowledge goes up, you'll have less stress, and you'll be motivated to do more exercise and eat a little bit healthier. Your weight would go down, and your quality of life would go up. We were able to recruit, we recruited over 600 people, but we randomized 443. And the randomization was really critical. It was a random number generator, so if you didn't get into the Steps to Your Health program, you got into the hygiene and safety program. You went to the same number of classes, you had peer contact, so we ruled out sort of the placebo effect of being in a trial by giving everybody got a notebook, everybody got, the same number of prizes. And people who lived in the same household, if it was a group home, were randomized together, but we only counted the first person in the house in the 443 to be, to have data collected on them, although everybody got data. So we had a number of different groups. They were all 10 to 12 people in size, these groups, classes. The measurement included all these things, the accelerometers. Of course, we did height and weight. We did dietary measurements. We did knowledge measurement, quality of life measurement, all these things. And here you see a sad fact. There's enormous dropout rates. One of the things that is a byproduct of person-centered care and being able to exercise your rights is people say no. And although we got good funding from the CDC, we could only give $5 gift cards to everyone at every weigh-in. And we wanted to follow people for a full year because it doesn't do any good to say they did have these positive outcomes at 8 weeks. Who cares if they're going to gain it all back and stop exercising over the course of 6 months and a year? So we did a lot of follow back, and we lost a lot of people because in summer months in South Carolina, it's boiling hot, and they didn't want to wear that accelerometer around their waist, and that they realized very quickly that that $5 gift card didn't get you very much at Walmart. So we had a very high dropout rate, and that could be fixed in another study, but it's a lesson learned, an important lesson learned. These were the names of the classes, and believe me, everything was about cooking and cooking together, sharing exercise time before and after every group. There was a walk. This was very participatory. And this was the comparison group. I said they went on for 8 weeks. They had a lot of fun. They had a good time. They did a lot of things together as well, nothing related to physical activity or eating, healthy eating. These are the characteristics of the participants. Their average age was 39 years old. Their BMIs on average were obese, above obese. You can see the distribution for the different categories of overweight and normal weight. It was about half and half men and women. We have, South Carolina is about 30% African American. We had a high African American participation rate. You can see the housing, group homes, and family living were the two most common. And then these are years in school, typical for people with ID. Okay, we also assessed the environment. As I said, that's an important contributing factor. Every measurement was done at the person's home. The staff, the individual, the family, and the assessor all agreed on sort of the answers to the questions about lighting and the neighborhood. We let the person only characterize the safety of their neighborhood, whether they were scared to go out after dark or not. But these were all components of the study. And we also did a food availability checklist, which was important. We looked at their actual cupboards. People let us open the refrigerator, inventory what was there, and also look in the pantry, see what was there. That was really important. You eat what's there. That's the bottom line on that. We did the stress inventory, and I don't have time to go through this, but we measured it. Life situation, we measured that. We did a lot of measurement. And then you can see that when you just look at the raw percentages, nothing happened. There was no difference between the comparison group and the case group. Nothing happened. But when you looked at a logistic regression, a more more sophisticated way of doing analysis, able to control for more factors, we found that people who lived in group homes were more likely. People who were in the program, Steps to Your Health, were 3 times more likely to have a change in their BMI in the positive direction, in the negative, down. People in group homes were more likely, and of course, if there was less fat in their diet, they were more likely to lose weight. Availability of physical activity resources was another outcome that we were interested in. This was really more observational than anything else, but group homes had a better record in terms of availability. So basically, we found out that there was more BMI reduction, and it was statistically significant in the case group than in the comparison group. People who over a year of follow-up, that persisted, and we found that people who lived in group homes were more likely, and I think it's the issue of support. They were targeted together. So as I said at the beginning, if they enrolled from a group home, everybody could come, and if they lived at home with their parents, they weren't invited. And so everybody has to get the same information. Everybody has to have the same buy-in to make these things work. Anyway, that's the end, and I'm happy to talk to anybody about this project, which isn't continuing, and any other issues. Thank you.